Hi, I'm Adrian Rollins. Welcome to AMA TV. The Abbott government is considering a fundamental change in the way GPs are paid, including a shift away from the fee-for-service model. Among the options being considered is a so-called capitation arrangement, where a GP receives an annual fee for each patient rather than a fee for each consultation. Proponents say it would encourage doctors to spend more time keeping their patients healthy rather than just seeing them when there is a problem. Health Minister Peter Dutton has shown an interest in New Zealand's blended system, where capitation fees make up about half of GP income. Today, AMA TV talks with New Zealand Medical Association Chief Executive Lesley Clarke to find out what capitation has meant for GPs in New Zealand and what doctors in Australia might expect.
If you look at the contract that is there with the PHOs who receive the capitation funding and then allocate that out to general practice, what they're purchasing is what was called first level services. And but there is no kind of list of this type of procedure or that kind of consultation. It's actually a very broad description, and that description includes health promotion, it includes health maintenance, it includes restoration of health, and it includes coordination of care. So very sort of all-encompassing sort of envelope of services that are expected to be delivered as first level services under the capitation funding contract. I mean, the reality is that in terms of the health status and improving health outcomes by making this investment in primary care, you know, if you think about some hard performance measures around that, one of the ones that is often looked at is avoidable hospital admissions. So if primary care is doing really well, doing the right things at the right time, you could logically expect that avoidable hospital admissions would be reduced. The reality is, if you look at that data during the time that the capitation system has been in operation, it's essentially flatlined for the general population. So our avoidable hospital admissions for the general population, they haven't got worse, which is good, but they haven't improved as we would have hoped with this sort of approach. And the really unfortunate thing is, with our Maori population, which is 15% of the New Zealand community is Maori, and they tend to be vulnerable communities with particular chronic health conditions and prevalence and things like rheumatic fever and things like that. The avoidable hospital admissions for Maori have actually continued to climb, and that's really disappointing. So that suggests that the capitation approach in primary care has not achieved those sort of outcomes. What it has achieved is more affordable access to primary care than we would have had otherwise. And that's important. That you know, logically would suggest to you that there is improved access and therefore a greater level of delivery of services, and hopefully over time we'll see improved health outcomes. One of the challenges in terms of making it affordable, or if you made it free, is that you're just encouraging the worried well to demand more of the health service than they would if you know, if they had to pay for it. And I think that was one of the reasons why the government at the time, when they were considering the capitation model, decided against a fully funded capitation model where the whole of primary care was funded in a way that services would be free to all patients. Because there's a sense that the co-payment helps manage that sort of demand. It also gave doctors and other health professionals working in primary care some confidence that they could still influence their own destiny, so to speak. So they weren't completely at the mercy of the government and the fiscal constraints of the day around what their remuneration was going to be, that there was potentially that offset. Capitation, for most practices, it can range between 40% and 80% of their revenue. The reason it varies is because it's population specific. So if your population profile is such that you have a lot of elderly people, or you're working delivering services in a high deprivation community, your capitation funding is actually, it's weighted so that it's actually higher. So that's why there's that difference. But against your capitation funding, you've also got the ability to charge a co-payment. Now, the co-payment piece of it is not a free-for-all. Co-payments are monitored, and at the start of the process, when they brought in capitation, that essentially sort of set a baseline for co-payments, and then year on year, the district health boards, where their funding originally comes from the Crown through the district health boards, will determine that it's appropriate for you to increase your co-payment by up to 2%. If, because of your practice situation, viability issues, things like that, you feel that you need to increase your co-payment by 5%, there's quite a few hoops that you need to jump through. You've got to go through to an independent fees review committee and so forth, and justify why your co-payment increase should be higher than the district average. So while you've got co-payments there, there are limitations on what you can do. Even more so if you've chosen to be a very low cost access practice. Now, for very low cost access practices, not everyone can be one. They service target populations. So for example, if your population is more than 50% Maori, you can apply to be a very low cost access practice, which means you get a significantly higher level of capitation funding. But the trade-off with that is your co-payment is specified by the government, and at the moment it sits at $17. And so while it can look like a really attractive option to start with, you are then completely in the hands of the government in terms of your total practice income. So, we were quite concerned for our members when they were considering doing this, that while the numbers might look attractive now, in 5 years' time, is that funding actually going to keep up with your costs of delivering service? But it was a really difficult choice, because in some areas in New Zealand, for example, Whangarei in the far north, very high Maori population in Whangarei, the majority of practices went into this. So if you were a practice who didn't take a very low cost access contract, potentially you were getting less in capitation, you had to charge more in co-payment, but your patients would know, why am I paying $45 to come and see you when I could pay $17 to go and see the doctor around the corner? So for some, there wasn't a huge amount of choice for them in making those decisions. And a very complex and challenging situation has since arisen. And we're actually lobbying the government at the moment about changing that policy approach. I mean, we're fully supportive of targeting, of improved or better funding for vulnerable communities. We think that's the right thing to do. But doing it on a practice basis like that, rather than on a patient basis, is a very blunt tool, and it creates some really difficult challenges within the systems. And I think overall for general practice, and there are exceptions to this rule, but overall it has been a positive thing for general practice in terms of certainty of revenue, the ability to be a little bit more flexible with how and where they spend their money and that sort of thing. So they've moved from being a business that was essentially throughput related, totally around episodic care. The more patients you had through your door, the more profitable your business was. Now, there's still an aspect of that because the co-payment piece of it, exists, but there's also this core funding that is there that you get per patient, even if that patient doesn't need to come and see you very often. So there is that incentive to keep your patient well. And I think that has created some space for innovation, for some new services, new ways of looking at things. I think, as I said before, what we haven't seen is that hard data around improved health outcomes as a result of that. So it hasn't transformed the delivery of primary care services. It's transformed the funding structure, but not the actual delivery of services. It was interesting because we currently have a national government, and they came into power in 2008, and it's been an interesting time for us because the oppositional shadow minister for health that came in as minister has stayed minister for the last 2 terms. So we've had a huge degree of continuity there. And one of the questions he asked the sector when he came in is what needed to change in primary care. And I think the message he got from the sector was that this arrangement and primary healthcare organisations was still relatively new at that point in 2008, but there was a sense that it could work, and don't throw the baby out with the bath water, essentially. So he did pursue some changes. I mean, back then we had 82 primary healthcare organisations. So, and the range was from very big organisations like ProCare in Auckland to very small PHOs, and the degree of capacity and the ability for them to support their general practice and their general practitioners was highly variable. We've gone through a process of rationalisation. We now have something like 30 PHOs. So while the model hasn't changed, there's been a shift and a rationalisation within that structure. Who knows what will happen with the general election. I think there is a likelihood that the current government will continue. But if Labour comes in as the new government, they were the architects of this to start with, so they're very unlikely to throw it out and start again. What we're asking them to do is to tweak the things that are not working, and the things that are not working are, for example, the very low cost access things, because it's created all sorts of anomalies in the system and left some practices really struggling to survive because they're now part of that and they feel that there's no exit pathway for them. So that sort of thing needs to happen. I think the model itself is very unlikely to change. We've also got a big piece of work happening that I think will have support regardless of which way the elections go, and that's about looking at incentivising improved performance in general practice.
Yeah.
But the idea is that it actually flows on through general practice and up into secondary services. So they're hoping that the sort of performance measures that they're putting in place are actually system-wide, and that that they're actually pitched in a way that encourages integration between primary care and secondary care, hopefully then of course for the benefit of the patient and the health sector generally. So I don't think we'll see wholesale change. Hopefully we'll see some tweaking of what's not working, and hopefully we'll see some investment in that kind of new ways of doing things, rather than just let's improve access. Let's actually look at what we're doing and how we're doing it, and resourcing that so that those health outcomes, the avoidable hospital admissions or whatever other measure that you want to take, we start to see some gains in that, and particularly gains for those vulnerable communities like our Maori population, where we're not seeing the gains that we hope that we would see.